A very good evening to everyone, and a warm welcome to all who have joined in and the esteemed speakers who are in this panel discussion on the occasion of World Asthma Day. The series of these discussions is National Virtual Forum Asthma Awareness, which is brought to you by Voice of Healthcare in association with AstraZeneca. The topic of this discussion is asthma and severe asthma, signs, symptoms, management, and a patient story. And to speak about it, as I said, we have an esteemed set of panelists whom I just go ahead and introduce. We have Dr. Deepak Talwar with us. Sir is Senior Consultant and Chairman, Pulmonology and Sleep Medicine at Metro Hospitals and Heart Institute, Noida. We have Dr. Priti Meshram with us. Ma'am is Professor and Head Pulmonary Medicine at GGMC and Sir JJ Hospital, Mumbai. We have Dr. Divya Shree with us. She is Consultant Pulmonology at Manipal Hospital, Jayanagar. Also, while sharing her expert views, Dr. Divya will also be leading the conversation with the rounds of questions. And also, just to add, towards the end of this discussion, we'll also hear an interesting and inspiring patient story as well, directly from his words. So, I think without further any ado, I'll hand it over to Dr. Divya and then she can take it up. Thank you.
Hello, everyone. Good evening. Welcome to today's asthma awareness discussion. I shall be doing the moderator. I will be moderating today's panel discussion. As we all know, asthma, which is one of the major non communicable disease affecting both children and adults. The burden of asthma in India is substantial, but yet remains underdiagnosed and undertreated. The latest WHO Global Asthma Report 2018 says among 1.31 billion Indians, about 6% of children and 2% of adults have asthma. Still, a lot of patients consider asthma as a stigma and therefore conceal the disease. So now the World Asthma Day, which is held on Tuesday every year's May month, is about to raise awareness about the asthma. This year's we'll be celebrating on May 3rd, that is today, and the theme being closing the gaps in the asthma care. The objective of today's discussion is all about asthma and in detailed discussion on it. The agenda is as follows. The first 50 minutes is about the insightful and inspirational questions, interesting questions to our speakers. And the next 5 to 10 minutes, one of our patients will be sharing their personal experiences and followed by the questionnaire sessions. The questions, we shall be collecting it in the chat box and we shall address each question at the end of the session. Now, among the discussion, the flow is as follows. First, we'll be talking about the basics, the treatment options available in asthma, safety of the inhalers, few questions about the severe asthma, lifestyle modification, and lastly about the COVID and asthma. Thank you to our speakers. I shall start my first question to Dr. Preeti. What is known about the asthma?
Okay.
What is asthma? Who gets asthma? What age it starts and what causes asthma? Dr. Preeti, to you.
Yeah. Good evening, all of you. At the outset, I would like to thank all of you for inviting me to this session. Patient awareness is very important when it comes to bronchial asthma. Now, asthma is a disease that all of us have heard about. It is a very common disease. I hardly think there mustn't be anybody who hasn't heard about it. It's either in the family or it's in your friends. Somebody or the other person must be suffering from bronchial asthma. Now, what is bronchial asthma? Bronchial asthma is a disease that involves the airways. Airways are commonly called as the windpipes, the pipes that bring the outside air into the lungs. So, what happens in bronchial asthma is because of certain triggers, there is swelling in these airways. So, these airway walls kind of become thick. Also, these airway walls start secreting a lot of mucus. Okay, so because the airway walls become thick, there is a limitation to the flow of air from the outside to the inside and from the inside to the outside, which gives the perception of breathlessness to the patient. So because there is this airflow limitation because of the swelling, there is this sense of shortness of breath or breathlessness as we know it. Also, because there is a lot of mucus production, the patient also tends to have cough. Sometimes he may bring out this mucus, sometimes he may not bring out this mucus. So the cough is, the cough may be with some mucus or without mucus. Also, because the airways are usually narrow, the patients have kind of a wheezing quality or a musical quality whenever they cough. Okay. Uh, Also, not only are the airway walls involved, but there are certain muscles outside the airways, even they become stiff. So that also subsequently causes narrowing. So this is a nutshell as to what asthma is. Basically a disease of the airways where the airways become narrower and you find it difficult to breathe. Okay. So the symptoms are related to what actually happens in the airways. And asthma, there is no age limit at there is no age as to when asthma can occur. Asthma can occur at any age. Asthma can occur as early as before 5 years of age, and as late as even adults who are 40 and 50 can get asthma. And when patients who are more than 40 or 50 years of age, when they get asthma, then it is known as adult onset asthma. Mostly it is seen in the younger age group, patients in their teens and their 20s. That is the commonest type, that is the commonest age, but you can have asthma occurring at any age. Okay. So age is, we do not have any specific age at which asthma can occur. The other question that you asked me was who would get asthma. So a few of us are predisposed to getting asthma. It sometimes runs in families. So there's, you would have your patients telling my grandmom had asthma, my mom had asthma, and now even I have asthma. So there is definitely a sort of a genetic predisposition to getting asthma. So it may run in families, but apart from running in families, people who smoke, people who live in highly polluted areas, they are prone to getting asthma. Patients who have recurrent allergic rhinitis or recurrent colds. Okay, so more than 50% of the asthmatics usually tend to have a lot of cold. So patients who have recurrent colds, patients who are people who are very obese, fat, they patients who have symptoms of acid reflux, patients who have acidity, all these kinds of patients are prone to getting asthma. So there are patients who would have it genetically predisposed, but there are certain external environments or external factors also that can predispose a person to get asthma.
Okay. So my second question is to Dr. Talwar. Is there a cure for my asthma or can I outgrow it?
Okay, so I think two questions in one way. Very nice to ask these questions. I would like to answer the second question. You can outgrow asthma. Yeah, so that's an easy one. You can outgrow asthma. That if you develop asthma in the childhood, then there is almost 1/3 chance that you'll grow up as a non-asthmatic, and your asthma will remain perhaps in a situation where it will not trouble you anymore during your adulthood. But this would only happen that if your asthma was well controlled during childhood. So if you continue to suffer, if you continue to have repeated attacks, then your lungs are going to remodel in a smaller way. They'll become smaller in size, and then perhaps your chances of growing out is practically negligible. On the other hand, when you are an adult and you are having asthma and you have been suffering for a couple of years, you can outgrow. That is a very difficult situation to say because it is unpredictable. Some of the people will actually remain symptom free for very long period of time. So I would rather call them as remissions rather than calling them as a completely outgrowing out of asthma. So these remissions in the later adulthood may break and lead to development of symptoms again and worsening again and development of symptoms again. So, but this also happens in only couple of patients, or rather a few patients, but not all of them. By and large, the second question is the most difficult one, that can it be cured? So there's no word which is cure in the asthma. So the word which we use in asthma is a control. Your disease can be controlled. You can lead absolutely normal life as others are. But that will be an equivalent to all other diseases which we talk about, which have got a long-standing lifestyle diseases like hypertension or diabetes, where you need to take your medicine. So similarly, in asthma, you need to take your medicine to keep you controlled, going, symptomless, and suffer with no consequences of asthma, provided you accept that you need to take the medicine. So cure word is something which is elusive at the moment. It does happen that when the patients become asymptomatic, they think that they are cured, but that's not the right interpretation, because they will be in remission at that point of time. Some of them accept low lung functions as their normal way of life and reduce their overall activities to accommodate that breathlessness in a way where it becomes more tolerable to them, and perhaps would like to say that that asthma is controlled without medicine. But I think that requires a lot of understanding from the patient's perspective, how they handle the situation themselves, how they interiorize the symptoms of asthma, and its tolerance to themselves. By and large, Indians are considered as very, very tolerant. They will be living happily with very poor lung functions. They will be living
Correct.
happily with suffering of almost getting breathless on climbing a couple of stairs or getting up in the night or having some amount of cough. And they'll consider this as a normal part of life. I think that's one of the reasons when you actually put them onto an asthma control test, they will be totally different in comparison to when you look at their symptomatology, because they say, we are fine actually.
Correct.
So you get totally disillusioned by the fact that why Indians are so happy in suffering from the limitation caused by asthma. So that's, I think, one thing which I always highlight, that you should live up to your full potential rather than living 50% life at a 50% lungs, and that's the situation.
Thank you for concluding that it is not a cure, but we can only control the symptoms. Thank you. Let's go for the treatment options available. What are the available treatment options? What are controllers and what are relievers? And another major question about all the patients asking about the addiction of the inhalers. To you, sir.
So this question is for Dr. Preeti or me or both.
So you can brief about the controllers and relievers and also about the addiction, sir.
So see, we have in the last 20 years have realized that asthma, when it comes as an acute attack and you use a medicine to relieve that attack, is called a reliever medication. So reliever medications has been conventionally a bronchodilator. I think Dr. Preeti have beautifully demonstrated to you and showed that these air tubes are getting narrowed. They are constricted. So if you give a drug to make them open again and let the air pass through easily, then obviously you are taking care of their symptoms of acute attack. So that's why they are called relievers. The second important point, also highlighted very well by Dr. Preeti, was that these are inflamed airways. So they are ready to, jump to constrict. So what it means is that any amount of stimulation which occurs from any source, maybe pollution, maybe allergens, maybe non-specific stimulation or viral infections, anything which goes and touches this inflamed airways, they immediately constrict. So what you need to do is you need to actually leave this airways less inflamed by giving some medications so that this inflammation is not there and they always look like what we say is a normal airways. And for that we use the drugs which are perhaps called as the controllers. So controllers are the ones which are trying to control the inflammation and keep the airways healthy and open. And if they get a sudden attack where they still constrict, that is because of the muscle component which Dr. Priti had already mentioned. You use a quick acting drug which leads to complete dilatation of them and relieving of symptoms, which are called normally the bronchodilators. Now, bronchodilators are like salbutamol, terbutaline, and these are the ones which are most commonly used in practice. And controllers are conventionally inhaled corticosteroids. So that is why, because the irrespective of whatever is the etiology, how you got asthma, your airways are inflamed. You need a controller medication, and controller medication is inhaled corticosteroids. There are number of them. They are like beclomethasone, budesonide, fluticasone, and the newer ones coming up. So there are so many of them which are available, but primarily these two group of there. Now recently the things have more or less merged together, where there is a concept of making the asthma treatment simple, because most of the times it happens that patients are told this is for controlling your symptoms, and this is controlling your disease, and this is for relieving your symptoms, and they invariably forget and try to use one for the other, and then mess up the whole treatment of asthma and get into an acute attacks. So now there is a concept where the reliever as well as the controller are both combined into them, and that can be used as a single inhaler for therapy, which you use at morning, evening, or once a day. And as soon as, but if you get an attack, you can use additionally same inhaler, because both of them are combined together. So there a bronchodilator like formoterol is added to another inhaled corticosteroid like budesonide, or the new ones are also coming up. But this is the classical type of one, which is called smart therapy. And patient doesn't have to carry two types of inhaler, only one type of inhaler is enough, which is this combination of both of them. So this makes the life for the patient more easy, and of course the less number of mistakes possible on that.
Okay. So, one question: most of our elderly patients who are long standing asthmatics come to us saying, I get relieved by a levosalbutamol tablet. What is your thoughts on it, sir?
I
Or a
think
terifilin injection?
right. So, see, I have grown from those years, I think 80s, when there were tablets only available. Inhalers had just come in 70s, late 70s. And people were hooked on to these asthilin tablets, thioasthilin tablets. And there was another one, Tedral SA, which used to contain phenobarbital at that point of time. I'm sure both of you would have heard about these drugs, because these were the main drugs in 70s and 80s when we were using it. And these, because they used to give a quick onset of action to the patients used to get hooked to it. Then came isoproterenol inhaler actually. So, and that was a very strong inhaler. It used to cause palpitations, but patient instantaneously used to get relief. So because these drugs give them relief, that kind of a thing, that is the one reason they use. Second is that there is a mental thought process in which the tablets are easier and acceptable, and inhalers are considered as no. So that's why I think you had put in the question of addictive. So if you know, I know this is a very common question. Everybody asks you that does it cause addiction? No, it doesn't cause addiction. If your disease is there, you need to take it. So if I have a poor vision, I have to use my glasses. I can't help it. So if my airways are narrowed, then I have to use my inhaler. I should not call it that it is addictive. If you are hypertensive or diabetic, you are taking your medicine. Are you addicted to them? No, you are taking them because you have a disease, and your disease cannot be cured. It can be only controlled. So I think that understanding has to be there. And for me, as far as tablets are concerned, yeah, I don't write any prescription in which the tablets are these which you are saying, because according to me, they cause more side effects. And there are, of course, they cause more palpitations, they cause more other symptoms which are related to it. And the dose of the medication is much more. It goes into the stomach, it gets into the circulation, and it loads you with that drug, rather than when you use it in inhaled form, where only a fraction of it goes straight into the lung, into the airways, which Dr. Priti had mentioned, which needs the medicine, rather than the entire body, by which the blood, it goes into the blood, the tablets. So no for the tablets, only the inhaled medication is the treatment for asthma.
Okay. It is very hard to convince the patient to go back to or restart the inhalers, and stop the tablets. It's very hard, sir. Ma'am, second question is to you. Do I still need to take inhaler if I feel okay?
Okay. Dr. Talwar sir has repeatedly emphasized that bronchial asthma is a disease that can be controlled. Okay, it is not a disease that is curable. So whatever inhalers uh, that we are taking to, or the patients are taking, they're taking it for control. So those inhalers are necessary to control the disease. And what happens if you stop the inhalers? Your disease would become uncontrolled. The patient would start getting the symptoms again. As sir said, there can be a period of remission. There can be a period where the patients are absolutely symptom free when the patients are taking inhalers. And that is the case when the asthma is well controlled. Now, asthma therapy, as we understand, we understand it, it's a step up and a step down therapy. So if the patient is continuing to have symptoms, what we do is go on adding medications to the existing therapy. But if a patient is feeling better, the doctor may decide to step down on the medications. Okay, now this process of stepping down on the medications, or deciding to see if the patient is doing well without medication, is completely the doctor's call and not the patient's. Okay, so whenever there is a change in the medications, that is adding up of medications, or stepping down and stopping the medications, that is completely the doctor's call. The doctor would decide how he would step down on the medications. He would do so for a period of 3 to 6 months, observe the patient, see if he's having symptoms again, then he may need to again go back to the original medication. Okay, so stopping medications just because you're feeling good is not the answer. As sir said, it is like if for controlling your blood pressure or controlling your diabetes, you have to take the medications every day. It's the same thing with bronchial asthma. If the asthma has to be controlled and the patient needs to have a good quality of life, as sir said, most of our patients are happy living at 50% of their quality of life kind of thing. But if you really need to have a symptom-free good quality of life, you have to continue with the inhaled medication or with the medications that the doctor has prescribed to you. It is always and always advisable to step down or change the medications only on the advice of the doctor and not otherwise. Because what would happen is once the patient stops the medicine, becomes symptomatic, there is a high chance that the patient would deteriorate further and end up in a hospital. So poor symptom control would land up in an exacerbation. Okay, so just the act of stopping his medication would not only give rise to symptoms, but in certain cases may give rise to such severe symptoms that the patient will have to end up and go into a hospital. Okay, so that is the extent that can happen in certain patients. So it is always advisable to change any medications, or to, even if you have to step down, to consult a doctor and not stop the medication on you.
Okay. Ma'am, any tests available to step down the therapy?
Okay, so the doctor uh, patients who are severely asthmatic or moderately asthmatic usually have a peak flow meter at home. They're taught how to use the peak flow meter, and a baseline peak flow rate of the patient is established, and based on that, on how much less as compared to the baseline the patient is blowing, the patient can put off, flag himself off, saying that okay, now I am not feeling better. Or the patients would start getting symptoms, daytime symptoms, nighttime symptoms like cough, wheezing, breathlessness. So it would be more symptoms, and if the patient has a peak flow meter at home, these two things would help the patient identify whether he is at a stable level, or whether he's kind of deteriorating.
Okay. Ma'am, any role of this institutional test, that is the lung function test or a PFT?
Okay, so the lung function test like doing a lung function, other tests like whenever a patient is breathless or whenever an asthma is suspected, if the patient is going to a doctor, the doctor would definitely confirm the diagnosis using these tests. He would do a CBC, he would get an X-ray test done to look, to see if there's anything else in the X-ray, if there's anything else in the lungs. Then if the symptoms are very classical of, clinically the patient is classically presenting as bronchial asthma, then the doctor would definitely get a PFT done. So PFT is an important tool in the diagnosis of asthma, because that would show, what we call in medical terms, even it would show an obstructive pattern with a good bronchodilator reversibility. So the PFT would show an obstructive pattern. You give bronchodilators like salbutamol, and it will show that the obstruction is reversed. Okay, so it has a good obstructive defect with a bronchodilator reversibility. Apart from that, to phenotype, especially if the patient is moderate or severe asthma, to know, if there are specific treatments. Now we have a lot of tailor-made therapies. So if these tailor-made therapies would be helpful to the patient, the doctor would go ahead and get absolute eosinophil count done, a serum IgE level done, He would also get an allergen panel testing done. Now these are allergens, there are a whole range of allergens, depending upon where you are. Suppose I am in Mumbai, so I know my set of allergens which are common. Sir is in Delhi. Delhi has its own set of common allergens. So we would all advise this allergen panel testing, see what are the common allergens, and we can then advise the patient, to avoid these allergens. So there are further tests that can be done, especially if the patient is, moderate and severe asthmatic.
Okay. Okay. Okay, ma'am. So, any side effects of the inhalers which I should be telling to my patients?
So side effects of the inhalers. So the common inhalers that we have usually contain steroids in combination with the beta 2 agonist. Rarely our asthmatics also prescribe certain long-acting muscarinic antagonists. But the commonest are the LABAs and the ICS. The LABAs at times can give rise to tremors and palpitations, but it is very rare. Most of the side effects, if are usually local. So now inhalers, as sir said, are very local. They act only on the lungs. Okay, so when I tell my patients, that inhalers are like ointments to your lung. You have skin ointments, so you apply it to the skin and it acts only at that point, and it will not have any systemic side effects. Inhalers are very similar. So the side effects related to inhalers are also very local. So sometimes if the patient is not gargling after a corticosteroid inhaler use, he may get a local thrush. He may get local oral candidiasis, local candidiasis, and hoarseness of voice. Okay, so that is the only commonest complication and commonest side effect, and it can be easily prevented by just simply gargling after every inhaler use. Okay, apart from that, hardly any complications, especially related to systemic complications which we see with systemic oral corticosteroids. Hardly any of it are seen with any of the inhaled corticosteroids.
Okay. So, next question is to you. How oral corticosteroids are different from inhaled corticosteroids?
I think Dr. Preeti has very rightly said it is like putting over the local surfaces of the airways which are inflamed. So you use inhaled steroids there. They are locally acting. So like you put it eye drops which have got steroids. You never ask the doctor that do they contain steroids or not. But when they talk about inhaler, they ask does it contain steroids or not. Yes, it does contain steroid, but the dose of the steroid is a very fraction. Maybe like it's a drop in the ocean, and it does not get absorbed systematically from the our airways and lungs into the blood to go and create the side effects which are caused by oral corticosteroids. So hence the oral corticosteroids should not be compared in the minds of the people that they are same as inhaled corticosteroids. Inhaled corticosteroids are locally acting steroids which are given for the local application, like we put it on the skin, we put it on the eyes, we put it in the nose, anywhere where locally acting steroids are required. We never ask anybody. In fact, for skin, I remember anybody will just use any skin ointment which contains steroids happily to get those scar marks out. And they will never ask a second time. In fact, the dose of steroids in inhaler is much less than that. The systemic absorption is much less than that. So practically, these steroids are dropped in the ocean. They do not cause any side effects. On the other hand, oral corticosteroids, which are infrequently used by the patients themselves, or it is forced to the treating physicians to use it because patient comes in acute attacks, they don't take their medications regularly, and once they take steroids, they learn that this is the drug of magic. So every time they will get an attack, they'll pop in those pills and slowly get addicted to them. And these are the patients who will get diabetes, they will have hypertension, osteoporosis, cataracts, skin thinning and bruising. Everything has been shown to be associated with it. That does not happen with inhaled corticosteroids. So by and large, Dr. Preeti has beautifully mentioned, there are only few minor side effects. Mild tachycardia, tremors, which goes away in 2 to 3 days time. Oral thrush, you can easily prevent by every time you use an inhaler, you gargle nicely and spit it out. And these kind of side effects are in less than 1 to 2% of cases. In fact, large pool of people who use, they don't get any side effects at all because there are no side effects. So I will say absolutely safe as well as non-addictive and very effective in management of asthma.
Okay. Sir, any risks of pneumonia in inhaled corticosteroids, sir?
So that's the question which comes infrequently in the science and research, that in COPD patients, it has been associated that inhaled corticosteroids decreases the immunity of the lungs and can cause colonization and subsequently development of a pneumonia. It has not been shown with asthma. So I think this should be very clear, that when we are dealing with asthma, inhaled corticosteroids have not been shown to be associated with increased risk of pneumonia. I know one day I saw one small little child, I think the child, not so small, maybe 12 year or 18 years, 12 or 14 years, he was taking inhaled corticosteroids and he developed pneumonia. And the mother came and said, "This is because of the inhalers which have you given them. That's what is causing the pneumonia." So I said, "Who told you?" He said, "There is a doctor nearby my house. He has said that he has recently attended a CME in which they said the inhaled corticosteroids causes pneumonia." Only thing he forgot was that it was in COPD,
It was
not
in
in a
COPD.
12-year-old child. So I think we get to know these kind of information from Google and other places in a half-baked and a half-truth manner. So please be very clear that this is not causing infections or pneumonias. If it is a pneumonia, it can be a aspergillus pneumonia, it can be ABPA, it can be diseases which are known to be associated with asthma, and they are the complications of asthma. And again, their treatment is steroids rather than actually taking off the steroids.
Ma'am, next question is to you. What are the indications for oral corticosteroids? When do we
Yeah,
use them?
so has just said one. So oral corticosteroids are like I told you how the management of asthma is. It's a stepwise treatment. So you start the patient on inhalers, not feeling well. You increase the dose of inhalers, still not feeling well. You add maybe you add another inhaler like a Lama to it, still not feeling well. Add a leukotriene receptor antagonist, still not feeling well. Add a low dose of oral corticosteroid. So these are patients who are chronically symptomatic. Patients who are chronically symptomatic and their symptoms are not going away despite all the optimized whatever inhalers you've given and other oral medications you've given. That is the time when you would add a low when a physician would add a low dose of oral corticosteroids. And in these cases, where the patient is persistently symptomatic, in these cases usually a low dose oral corticosteroids is added and it is continued for a prolonged period of time. Okay, so those are usually like what we label as maintenance oral corticosteroids. This is one condition. And the other condition that sir said earlier, that the patient is acutely symptomatic. He comes to the hospital with an acute attack, or he's exposed to a trigger. Maybe say that he's exposed to dust, or maybe he's exposed to smoke, and he's come to you in an acute exacerbation, and you need to relieve the symptoms at the earliest. That is the time when the patient can be given a very high dose of oral corticosteroid. So whenever so for a controller kind of thing, the oral corticosteroids are usually low dose and for a prolonged period of time. But in an acute setting, you can still use oral corticosteroids, but here the dose is slightly high and usually used for a shorter period of time. So oral corticosteroids can be used in these two conditions, but in different dosages.
So just to add on to what Priti said, that low dose maintenance corticosteroids is down in the list, the last treatment. So that's the last treatment to be given. And specifically now the GINA and our all guidelines tell us that the steroids are reserved in these situations. So acute attack, obviously everybody will use, no issues. But from patient's perspective, from their minds, it should be clear that if they are taking it for controlling their disease and they are using it continuously, this is the last resort medication which they are using, which they should not. And in that situation, they should go to the doctor and ask them what are the alternatives available. And if the alternatives are available, then see and explore how those alternatives can be used. And I am happy that the scare of steroids due to COVID is so much now that at least patients are more now understanding that corticosteroids, even for a month or 2 months, can cause harm. So they have started understanding those things, which all this COVID has taught to everyone. So there will be more dissemination of this knowledge required. But I think all patients should understand that if they are taking corticosteroids for more than 5 days or 7 days, then there is something wrong in them where they need to see a doctor and see that what is the best way forward, where they can actually eliminate or completely see to it that they don't require or don't use oral steroids.
Okay, sir. Let's discuss about severe asthma. What is severe asthma? What could be the early signs and symptoms, and how is it different from mild to moderate asthma? Over to you, sir.
So, see, severe asthma by the name itself tells us that the patient is having a severe disease. Now, this severe disease is primarily meant from two perspectives. One is that severe because patient is having lots of symptoms. Now, these patients' symptoms may be that the patient is breathless on routine activities. Patient may be having poor nighttime control of symptoms, getting up in the night with asthma symptoms, not able to perform daily activities. They have to use the inhalers very frequently. So this is a kind of, or even not able to attend to his business, to his work, to his school. Everything gets affected. The life of the patient gets affected because the symptoms of asthma are actually poorly controlled. But on the second hand, the most important aspect of severe asthma is that patient is on a whole lot of medication. That is inhaled corticosteroids, long-acting beta-2 agonists, LAMAs, which Dr. Priti mentioned, three most common drugs. And in Indian scenario, we are using theophylline, montelukast, all these drugs which are available in various companies and various names and various combinations. The patient is taking all of them. If the patient takes this high intensity medication, we call high intensity because most of the patients don't need that. Only about 5 to 7% of patients will require that much of medication to control this disease. And 3 to 4% of them, even on these medications, will continue to suffer because of poor asthma control. So, if that is the situation, what happens, we call them as severe asthma. And we also try to see in these patients whether the patient is really taking the medication, whether the patient's medication is really getting down into the lungs, that means their techniques are correct or not. Diagnosis of asthma is established, like Dr. Preeti said, we do the lung functions to establish the diagnosis of asthma upfront. So we need to do, if it has not been done, then we also need to see that patient may be having so many other diseases along with it. They might have bad nose and sinus disease like rhinitis, sinusitis. They might be having severe gastroesophageal reflux, which Dr. Preeti also mentioned, obesity. There are so many other comorbidities, obstructive sleep apnea, which can cause asthma symptoms worse. After all, asthma symptoms are three: cough, breathlessness, and wheezing. They can be caused by all other things, and you should not be confusing it with asthma. But if you have done all that well and you find that it is asthma which is poorly controlled despite taking this all medications, then that is severe asthma. Mild to moderate asthma, on the other hand, is easier to control. The patients are very happy with the medication. They don't have to, they only get troubled when they stop the medication. But otherwise, if they take medication, they are healthy. On the other hand, severe asthma group patients are those who continue to suffer despite taking their medication. And we need to really put our minds and brains and to work, why their asthma is not getting controlled. And there, I think what Dr. Preeti again mentioned very nicely, we do a phenoendotyping, try to find it what is going on inside the lungs of the patient, which is not allowing them to become better with the all lots of medication which we have used, and the patient requires even oral corticosteroids for that. So that is a separate group, blissfully very less in number, but sadly, these are the people who suffer most. They get into the hospital most. They get hospitalization most. They see the doctor frequently. And of course, the entire expenditure of whatever is spent by the country on an asthma care, 80% of them is mopped up by this 3 to 4% of population of patients called as severe asthmatics.
Okay. Ma'am, next question is to you. How will this severe asthma episode impact the patient's life and the family members and the society?
Okay, so has already mentioned that severe. They are a very short percentage of the patients actually. 3 to 4%, as said. A rough overall estimate seems to be less than 10% of the total asthma population. Okay, so most of these patients are taking all the medications that are available for asthma, and despite that, they are remaining symptomatic. So they end up having daytime symptoms, nighttime symptoms. So it definitely affects their quality of life, and because they are poorly controlled, they tend to have a lot more exacerbations. Now it is estimated that patients who are poorly controlled have 15 times more exacerbation as compared to patients who are not controlled at all, patients who are well controlled. Okay, so the amount of exacerbations that these patients tend to have is definitely much higher than the patients who are mild to moderate, and patients who are well controlled. If there are exacerbations, then the patient is likely to visit the hospital, likely to visit his doctor. Even if he, postpones visiting his doctor, he's likely to visit the hospital in an emergency department, because he has, postponed taking treatment for his symptoms, which is going to actually worsen the symptoms and land him in an exacerbation, or land him in a very poor symptom state, and because of which he is probably going to visit the hospital or visit the emergency department. And this is supposed to be, the hospital emergency departments are, estimated to be around, 20 times more as compared to the other asthmatic population. And most of these hospital visits or the emergency department visits end up in the patient getting hospitalized, because the patient is sometimes so sick that, a simple ED visit is not going to help him get out of the episode of his severe asthma. So the patient may require to get hospitalized, may require to stay in the hospital for quite some days. And an average stay for an asthma exacerbation is anywhere between 5 to 7 days. So in this whole process, where he's utilizing a lot of medications, despite that remaining uncontrolled, having multiple hospital visits, having multiple episodes of hospitalization, so these patients end up using a lot of the resources that are available for treatment. Okay, so severe asthma patients are supposed to be using up almost 80% of the resources that are available for asthma treatment. So that's a huge thing, so they end up, in terms of, the society and for the family itself also, because the patient is getting hospitalized multiple times, he ends up paying that many times more. So he's spending from his pocket, because he's getting as hospitalized, because he's not well, he's probably not going to work if he's a working person, so he's missing on his work days. If the patient, is working on a daily basis, on a daily wage basis, he's out, he's going to miss his daily work pay as well. So it is a lot of financial. And because the patient is always symptomatic, the patient is not feeling well at all, so it's also a lot of emotional and psychological harm, also not harm, or psychological effect on the patient that is going on. So most of these patients tend to be depressed. They feel that, there is this feeling of impending doom that is always there. So sometimes we need to refer these patients to a psychologist as well. So it's not only a respiratory ailment, it becomes a psychological ailment as well, that is affecting the patient's pocket, that is affecting the overall healthcare resources also. This whole thing of, the finances being affected, the emotional stability being affected, this would affect the family as well. Okay, so there is an overall, so a single asthmatic would ultimately not only himself be symptomatic and distressed, but and ultimately ends up causing quite a lot of distress to his family, and ends up using a lot of resources. So it's like if you say, it's like a snowball effect, him, the family, and then the healthcare resources getting affected. So it's quite a big thing, for one asthmatic who's uncontrolled, it becomes, a lot of other things also get affected.
Okay. How do we approach them, ma'am?
So patient.
Management wise.
Okay, so sir very nicely said. So we have a very small population of these patients. It's less than 10%. Sir said, 4 to 5%, which is very true in our setup. I'm very sure we wouldn't get more than 4 to 5%. It's partly also because our patients tend to get used with the kind of lifestyle that they have. But as sir said, that we these kind of patients who are very difficult to treat, or who remain uncontrolled despite a lot of medications, we need to phenotype them. We need to do their serum IG. We need to we need to do their absolute eosinophil counts, see if they are the allergic type, see if they are the eosinophilic types, have a look at the comorbidities. So then more than 50% of these patients tend to have rhinitis or sinusitis. So it's very important that we treat the rhinitis, sinusitis. Most of these patients are obese, then we need to refer them to a dietitian, or need to refer them to a weight loss program. Okay, so we need to control the other comorbidities. The patient has a gastroesophageal reflux, we need to see that his reflux is in control. So if the patient is having OSA, see how much is the obstruction, put him on a CPAP. So all these other comorbidities, we have to take care of them, so that we have optimized. We have to look at the inhaler adherence as well, see that they're using the inhalers properly. So all these other small things that come with asthma, we have to take care of them, see if they're still if they're still unwell, then we definitely upfront also nowadays in severe asthmatics we do a absolute eosinophil count and do an IG, and then uh, decide about the other available treatments now. No, so we now are in an era where we have injectable biologicals available. We have three of these biologicals available. So usually omalizumab is reserved for the asthmatics who have a very high IG. We have the other two, that is the mepolizumab and the benralizumab, which act specifically on the eosinophils. So if you have patients who are the allergic type, or if you have patients who have a high eosinophil count and who have a late onset asthma, maybe then in those patients we can give mepolizumab and benralizumab, and in the atopic times we can offer this treatment, rather than offering them oral corticosteroids. So this is how we would go in patients, in these small subset of patients. This is how we would go ahead and manage them.
Okay, thank you, ma'am. Touching upon the newer modalities of treatment also. So let's go for the lifestyle modification which a asthmatic patient should have. What are the kind of exercises or the compromise in the activities they should have? Any specific rehabilitation exercises in particular for asthma and other things?
This question is to me.
To sir.
Okay, I think Priti would be happy to answer this question equally. So I'll just say that one, the exercise is not prohibited to asthmatics. They should do exercise, and if exercise produces asthma, they need to bring it to the attention of the doctor so that they can manage that. There are certain people who will become bad with the exercise, and it is called exercise-induced asthma, and they need to be treated for that. So that's not a problem to treat this kind of a disease. Only thing is that people should not shun away from exercise thinking that exercise is not for us. They should do exercise. They should increase their exercise capacity, and simple running and walking and all relaxation and stretching exercises are perfectly fine with them. So lifestyle modification does not require only exercises. It require a good diet plan, any diet amount which causes more reflux, acidity, and regurgitations. They produce bad asthma control, or the alcohol and other things, which again worsens the situation of gastroesophageal reflux, may again increase the asthma symptoms for the patient, making it difficult to control. So these kind of a good diet, good sleeping habits, good exercise regimen is a very important component. Maintaining healthy weight is also a very essential component of it. Invariably, we see over a period of time that poorly controlled asthmatics, they tend to gain weight, not only because they consume steroids, but also they become physically inactive over a period of time. They feel that they are breathless, so they should not walk, they should not do for exercise, they do nothing. So this kind of all things have to be actually taken in a different perspective, where all these are allowed, and actually you are supposed to live a normal life. So if you are an asthmatic, there should be no restriction of activity. So if you have any volitional or your hobbies or everything should be done as a normal person do. Let there be no limitation of any kind of activity. But yes, a good lifestyle to be maintained for an asthmatics is very essential and kept in mind. And at the end, a good sleep is also very, very essential for them. And rest, I think Preeti can add to it.
Okay. Ma'am, any home environment changes with the patient should take care of?
Okay, so most of our patients, no, so whenever we diagnose a patient with asthma, we generally tend to do an allergen testing panel, and we commonly find that dust mite is the commonest offending agent most of the time, so the commonest trigger. So, we can suggest certain dust control measures to the patients, like, usually whenever there is a mopping done at home, it has to be done with a wet mop, or use a vacuum when cleaning the homes. They have to wash their upholsteries and their sofa covers and their bed covers and pillows in warm water. So usually use warm waters, that kind of, a temperature of 60 to 65 degrees usually centigrade usually kills the dust mites. So we can have certain, if dust mite is the commonest offending agent, so we can actually recommend these controlling measures to the patients. quite a lot of patients are allergic to animal hair, that is cat dander and dog dander. So we can recommend that the pets, pets can be kept out of home, so that not much of the hair is at home. So that that can prevent the trigger can be minimized. Smoke is another common offending agent. So most of the times it's if there is a person who is smoking at home, so we have to tell about that, avoid smoke. A lot of the other times is more of the household smoke. Mostly in India we'll find agarbatti or incense smoke is common. Or we have a lot of Indian houses also use these mosquito mats. I find that them to be a great trigger for asthma. You just simply ask them to stop using that, the patients are symptomatically much better. So you have these certain small things. Food, a lot of food items can, especially peanuts, not so much in India, but a lot of food items can also act as triggers. So we can have general measures, but we can have also the specific allergen related measures also, that can be explained to the patients. If there is pollen, then we can ask that during the pollen season it's better to shut off your windows, but then you cannot refrain the patient from going outside. So but a basic thing like shutting the windows during pollen season would help a bit to the patient. So we can advise such measures to the patients, such environmental control measures to the patients, that can basically not eliminate the triggers but minimize the triggers.
Okay, ma'am, few words on the fruits. Most of the asthma patients tend to have this thoughts that if they have banana or apple or anything for that matter will trigger their asthma symptoms. What is your thoughts on it, ma'am?
Okay, so Indians feel that bananas and lemons can trigger asthma, but you need to confirm whether the patient is really allergic to this or not. So you either do an allergen panel testing, or you do a you do a skin prick testing to find out if the patient is really allergic or not. And if he's really allergic, so quite a lot of patients can still be allergic, and if he's really allergic, you avoid. So I because you do not know what triggers. So if it is really triggering, then you can avoid. But if most of it is mostly hearsay, the patient just has heard it from somebody, and it is not really an offending agent, then you really do not need to stop it. Okay, so you have to first confirm whether it is really an offending agent, and then go ahead and prescribe whether to stop the offending food or not.
So in India, we have a mentality, that by avoiding certain food items, you can cure the disease actually. So that is in the mind of everybody. So to the extent they will stop eating almost everything to think that they can cure their asthma without taking medicine. I think, and this is something which is very bad, and we still see this in 2022. If you see a patient who's avoiding 90% of the food items, thinking that she can manage without inhaler because she has cut down everything and lost 10 kg, then that is something which is not correct, because nutritional deficiencies end up in these patients and they become very, very immunologically weak. So I think that perception has to change.
True, sir. So last few words on COVID and asthma. Should I continue inhalers and other things during the COVID time?
So absolutely safe inhalers to be used in COVID times. 2 years we have taught so many things, learned so many things, and retaught people with the affirmation of the new data that inhalers are absolutely safe. There is, on the other hand, a suggestion that those patients who were on inhaled corticosteroid inhalers did much better when they got COVID in comparison to the people who were not on inhalers. So in fact, there is a silver lining to the asthmatics, that they continue their medication regularly. Their this controller inhaler, particularly, which you spoke about in the beginning, they have some protective role as far as COVID is concerned. So I think this is one of the reason that initial part, I think initial 6 months of the COVID lockdowns, asthmatic patients did perfectly well. Actually, they were so good, so happy. One, because they were scared, because they were told that because they have asthma, they will become worse. So they stick on to their medications, absolutely. And second, there was no pollution to make the things bad for them. And in fact, they did very well in the first 6 months. Then only after the next 6 months, but still, in anticipation of whatever we thought of that these people will do very bad when they will get COVID, we realized that they actually went off with the COVID just like a breeze. So they never had those problems which were anticipated. So COVID, please continue with your inhalers and take your COVID vaccination. There is no way to be scared of COVID vaccination because you have an asthma.
Okay. Thank you, sir and ma'am. Now I shall welcome one of our patient who will share his personal experience. Ranjit ji, namaste. You can share your experience. So switch on your mic. Mic on कीजिए.
Hello, everyone. Good evening, doctors and all person, all media. Talking about myself, I am Ranjit Singh Mata. Talking about my age and profession. For me, age is just number, but still I am 60 years of age. Regarding my profession, I am retired class 1 central government officer. I work as a field assistant in hydrographic survey department. I was suffering from asthma since childhood. I have visited many doctors, many physicians, specialized chest physician for the treatment of my asthma. This doctor performed many tests and after which they confirmed that I am suffering from a bronchitic asthma, a severe form of chronic asthma. Although it is very difficult diagnosis for me to accept, but I have to accept it as part of my life. Then I was performed with many inhalers and medicine for asthma. I visited many physicians, but my central government physician referred me to the specialist chest physician, Dr. Priti Meshram at JJ Hospital, HOD, the chest physician. Performed many investigations and confirmed that I was suffering from bronchitic asthma and chronic form as asthma. Then the doctor explained that a new personalized treatment called biologic is available for severe severe asthma patients. This advanced treatment will not only help improving the system that will also reduce the oral steroid doses. The doctors told me about the new asthma drug called ben, ben, benazirazuma, a personal treatment that target is I really thank God that with relief at the thought that there is might something that could help me feel better. I have received this injection in September 2021. Just 2 weeks after this first injection, I could perform my day-to-day activities without any difficulties, which was a task earlier. After 3 injections, I resumed my full-time activities, which I thought I shall never be able to do again. Along with my symptoms improvement, I could reduce my oral steroid doses by 50%. My doctor Priti Meshram is helping me to maintain a health and fit life with the help of exercise and good diet. I feel better and more energetic that I feel in years. This treatment has transformed my life. I thank you very much.
Thank you, Ranjit ji, for explaining your experiencing your asthma symptoms, sharing about the treatment options which you had taken initially and later escalated to the biologicals. Thank you.
you, madam.
So now I think we shall end the session. If we have any questions, I shall take it up.
Thank you so much, everyone, for enlightening us with all the things important regarding asthma, signs and symptoms, and awareness regarding it. And a very special thank you to Mr. Ranjit ji, who has so nicely shared his experiences. Thank you, everyone.
Thank you.
Thank you.
Thank you.
Thank you.